you so much for that introduction. So this work is part of a broad set of activities to analyze the dynamics of digital health markets in low and middle resource settings. The primary objectives are to understand the sustainability of various digital health solutions with respect to their delivery models, and to explore how different actors can play a role in delivering those solutions. From a market perspective, we looked at which digital health tools get introduced, adopted, and scaled, and the value that they bring. And this is based on cost, affordability, and potential impact. We will start by orienting the analysis around 4 provocative questions about how stakeholders operate in the digital health sector. Finally, as we all know, COVID-19 has implications on all of our work. And in terms of digital health, we have seen how health systems are increasingly relying on digital to share information and to support population health needs. So our 4 questions are: why did digital health innovations scale in low resource settings at different pace, sometimes slower and sometimes faster? Does development actor behavior accelerate or hinder the scale of digital health innovations? What are the biggest structural incentives preventing digitally enabled health systems? And last, what is the value proposition for digital health to investors, and for what cost? In our work, we tend to hear a lot about the dysfunction in digital health markets. But our research over the last year has demonstrated that there are examples of thriving digital health markets. The market for solutions with electronic medical record functionality in India is one such example. In India, you see many of the ingredients that are necessary for long-term sustainable participation by actors, and this includes government. There is a market for solutions with both clinical and administrative functionality, driven by government's push toward universal healthcare coverage and private hospitals' billing and operational needs. In addition, India has a rich ICT ecosystem in the country. A variety of local and international software firms have implemented that offer solutions throughout the country. And governments, as buyers, require that bidders offer end-to-end solutions. So the issue you see elsewhere of solutions running out of money for maintenance and support after a few years is less of a problem in India as it is elsewhere. It's important to note that while the market is working, it's definitely not perfect. There is both competition and choice in terms of solutions, but some lack interoperability standards, meaning that a proliferation of EMR solutions sometimes impose a burden on health workers who have to deal with more than one system. But sustained participation and competition is happening in India. So how did we come to these insights about EMRs in India? And this work was done in collaboration with VitalWave. We applied an analytical approach that supported our understanding of the sustainability of solution delivery, maintenance, and use. And this was conducted in in-depth analysis of the delivery value chain and the functions provided at each level of the value chain. The results provide a snapshot in time looking at the give and the get for each actor in the value chain. And the actors that we identified that are critical are funders, government program owners, software developers, system implementers, maintenance and support, and of course the users. We also assessed the risks that that value chain deteriorating or may become unstable over time. We applied this method to 4 different digital health solutions and evaluated their actual delivery value chains in 3 countries as shown on this slide. This gave us a view of different solutions and the strengths of their value chains in marketings of varying maturity levels. And Jenna will be speaking to the maturity levels more specifically in a few minutes. I just talked about India. In Kenya, the EMR and supply chain information system value chains are also broadly functioning, with a variety of local vendors selling proprietary EMR solutions to local governments and private hospitals, mostly for billing, but with clinical functionality added in later. You also have international vendors working on global good-based solutions at the national level, and you even have systems that are developed and maintained by Ministry of Health employees. However, when it comes to highly complex implementations, the country's ICT capacity starts to run its limits. In Mozambique, which is the least mature market that we looked at, is a different story. The government is almost entirely dependent on donors for funding digital health solutions, which leaves them with less influence when it comes to deciding on solutions, many which are funded in silos rather than holistically. ICT capacity is low in both government and the private sector, which means that most implementation and support must be provided by regional or international organizations with higher cost structures, and solutions frequently turn over. Finally, there is distrust of the private sector and onerous procurement regulations that mean few private firms can orient or compete, leading to a shallower pool of developers, implementers, and less competition. We started this section with India's EMR, and then we talked about the situation in Kenya and Mozambique. This heat mark is a way of illustrating where there is stress points in the value chain for digital health. Just as an orientation to the heat map, the top shows the different actors that we just described: funders, government program owners, software developers, system implementers, those providing maintenance and support, and system users. Broad solutions cover more functionality and more use case, and therefore they're more complex. And we also talk about narrow solutions, and these are solutions that have more limited functionality, like a record system designed for billing. That would be one example of a narrow solution. When the value chain is experiencing stress, meaning yellow or red instead of green, it's generally attributable to the following. If we look down the right-hand column, we can see that if we look down the right-hand column in terms of system users, we can see that it's functioning suboptimally because users do not get sufficient or sustained training. For logistics information systems, or LIS, the primary issue underlying the value chain is related to funding. There is limited funding for donors, for lab information systems, particularly in broad scope solutions. LIS is lab information systems. And SCIS is supply chain, EMR is electronic medical records, and MFR is master facility registry. For lab information systems, there is a mismatch between what donors are willing to fund and what governments say they want. For EMR, or electronic medical records, narrow scope solutions for billing and administrative functions are regularly being implemented and managed by subnational government entities, as shown at the top. However, for broader scope implementations, where there is more clinical functionality, and this is of more interest to donors, government entities tend to struggle to take ownership, maintain, or scale these broad solutions due to lack of financial and human capacity. Many of the factors here that I've been discussing relate to market maturity. So I think that this is a good time to transition over to Jenna and to talk about what the team found about market maturity and how it relates to these solutions. So Jenna, over to you.
Thank you, Tara, and thank you everyone for the opportunity to present today. I am going to be discussing some analysis that we did first on digital health maturity market segmentation. And this segmentation provides context on market opportunities and product development requirements. We divided countries across the globe into 5 digital health maturity segments based on the World Economic Forum Network Readiness Indicators. These indicators include political and regulatory environment, infrastructure, and digital context and skills. Level 1 is the least digitally mature, and level 5 is the most digitally mature. Our work at PATH and in Digital Square is focused exclusively on levels 1 through 3. And to provide a bit of context on what the lower digitally mature environments look like, so those digital markets 1 through 3, these completely lack digital policies or have planned policies that are not yet implemented. They also tend to have 2G infrastructure and variable electricity. Lastly, the workforce has less digital literacy skills. Most countries in the world are in levels 2 and 3, yet there are limited examples of products that have scaled in this market. Each maturity level has different capacities for adopting digital health technologies, and products targeting high and low digital health maturity levels have different product attributes reflecting different end user needs. Because of this, products struggle to serve populations across all of these markets. It is challenging for solutions such as global goods, which are open source solutions, to subsidize by selling in higher income contexts because they rarely have funding to adapt products to meet high maturity needs, and they frequently encounter strong competition from other software incumbents. This is a visual map of the digital health maturity market segmentation that I just described. As we can see, low digital health maturity countries, which are shown in green, are mostly in Africa and Southeast Asia. In contrast, most digitally mature countries, which are shown in blue, are in North America, Europe, and Australia. Interestingly, there are many upper middle income countries displayed in the middle maturity level 3, which is shown in this gray or light green color. And this suggests that income does not perfectly correlate with digital maturity level. So how do we apply this to our analysis? One way to apply the digital health maturity model is to understand how end user needs vary by different market maturity levels. As I just mentioned, products typically struggle to meet the needs across all digital health maturity levels. More specifically, the research and development that is needed to adapt a product from a high digital health maturity context to a low digital health maturity context often exceeds revenue gains. In addition, there can be a high cost to sell and erratic funding in lower digital health maturity markets, suggesting that incentives may be needed to adapt and move products from lower digital health maturity levels. As you can see in this slide, there are several attributes that we've identified that are necessary for low digital health maturity markets. These include offline functionality, or the ability for these tools to be used without an internet, SMS or short messaging, and compressing data to maximize storage. Other features such as artificial intelligence or machine learning and SaaS, software as a service, are critical for higher resource and market maturity levels. Oh, sorry about that. It's quite possible that we have spoken, that what we have spoken today is familiar to you, or at least is not a surprise. As a field, the digital health community has seen a lot of the same issues repeatedly over many years, over the last 10 years that we have been working in the market dynamic space and in digital health. What makes this work different is that we have analyzed or assessed market dynamics of digital health, focusing on identifying and understanding the root causes of the issues that we've observed. The majority of the root causes we've identified through this value chain analysis, looking at product and feature assessments and in discussions with our donors, have boiled down to these 4 root causes, which are shown here. First, there is a lack of authoritative and transparent market information on the full or total cost of ownership of digital health solutions, and this is particularly true regarding long-term operating expenses, which we will be discussing shortly. Second, there is a lack of equitable access to learning opportunities, which leads to talent gaps and long-term inability to operate these tools and systems in the markets where they serve. 3, financing can be unreliable and lead to lack of scaling. And 4, there is consistent set of incentives behind donor behavior that has consistent and unintended negative consequences on the value of digital health at the country level. This can lead to siloed and time-bound investments, which fail to capture efficiencies and develop cross-cutting digital platforms and further alienate end users. So our ongoing work is aimed at addressing some of the root causes of suboptimal market functioning. This work is building on the prior work that we just discussed and is also a work in progress. I am going to discuss 2 components of the work that are meant to address these root causes. 1, the lack of authoritative budget information, and 2, the incentives behind investor behavior, specifically the importance for investors to understand the return on investment or value for digital health. To address these root causes, the second phase of our analysis has focused on developing a total cost of ownership for a digital health intervention and cost outcomes analysis in terms of the health impact from that investment. To conduct the cost outcomes analysis of digital health interventions in low resource contexts, a common methodological framework typically includes a series of steps. This slide outlines the standard methodological approach for evaluations of impact and cost that we have used. This begins by looking at an intervention and the outputs and processes that lead to impact. So for this example, we used a logistics management information system, or an LMIS, and this impact shows the evidence-informed link between the digitalized supply chain interventions and health impact. The data that we collected inform the appropriate values that are used in the modeling of the health impact. And we also accounted for uncertainty based on other factors that may impact the outcome of interest. In this example, we looked at reductions in stockouts that were assumed to improve coverage of health commodities. This improved coverage leads to better health outcomes and use of health commodity data based on the intervention that we selected. The second analysis that we conducted looks at the total cost of ownership, or TCO, which refers to all of the costs associated with owning and operating a unit of equipment or technology. Again, this analysis was based specifically on logistics management information system. To note, the logistics management information system was selected because it allowed alignment between the cost outcomes analysis and the total cost of ownership that we just mentioned. It's the type of system with the most direct measurable impact on health outcomes, and we were also able to collect cost data from implementing partners. To note, the total cost of ownership implementation is based on a global good, so this is not a reference cost for a totally bespoke supply chain information system built from nothing. Instead, these costs were based on the adaptation of an existing global good. The TCO collected primary data from 5 countries for implementations that are in geographies with different levels of digital health market maturity. And this model implementation, which was used as the basis for the total cost of ownership, was selected for a market maturity level 2 country. We also collected cost data from 4 additional countries to assess the variances in cost on how variable costs may be different in countries with different characteristics. The costs across all 4 areas shown here, operations, planning and development, scaling and deployment, were broken down into these phases. One thing to note is that the analysis showed that there was a significant cost associated with the operations phase of the TCO, which includes ongoing maintenance and replacement costs, which are not typically considered. We also see that the phases of this costing are mostly sequential, so moving from planning and development, deployment, scaling, and onto operations. We believe that the distribution and allocation of cost may be representative of other systems beyond a logistics management information system, and that the big takeaway is the breakdown of costs by phases shown here. I will give more details on operating expenses next, because this is the least understood and transparent aspect of costs, and where some of the richest analysis and data come from. We also believe that this is the most likely to be under budgeted. This slide outlines illustrative variances in costs, which is important to understand in the total cost analysis that we conducted. This provides more details around the costs and variances from the operations phase of the total cost of ownership. And again, this is especially important because our analysis suggested that there is a lack of transparency and knowledge of the true total cost of ownership of a tool, especially in the operations phase. This oftentimes means that implementation budgets do not plan for long-term costs of ongoing operations, which can lead to underfunded and unsustainable deployments. You will see some of the biggest variances in cost found across the various implementations identified and the key cost drivers behind these variances. For example, recurrent training varied significantly based on whether resources were applied to classroom-based training versus on-the-job training by users. Implementation was able to drive huge reductions in cost over time shifting to on-the-job training. For maintenance, the degree of integration played a role in the variance in cost. Large-scale integration required skilled ICT resources to complete, driving up maintenance and testing costs. While we do expect long-term benefits from interoperability, a lot of effort goes into that, and this comes at ongoing operational costs. Equipment and replacement costs were lower at facilities using existing hardware, which was the case for the model implementation, and cut 90% of budgeted costs. However, it is important to note that someone did pay for these costs, and it wasn't just attributable to the logistics management information system. This can be difficult to evaluate the costs and equipment when these costs and equipment are shared across various systems. How to determine shared resources and a portion of costs was a big point of discussion in our analysis. Building a comprehensive 5-year operational budget that can be shared with all stakeholders provides a common understanding of the actual human and capital resources required across different cost categories. It identifies gaps in long-term funding and human resources and allows governments to discuss and plan for ownership of the digital health intervention. The output for this work is a budgeted framework and costing reference document, which explains the cost categories and components beyond what was shared today. And this budget framework and costing reference document will soon be on our online market analytics landing page for use by governments, implementers, and funders. We hope this will help create a realistic expectation on the cost for a specific software solution over a given time horizon, which in this case was 5 years. I will now move back to Tara, who is going to provide a wrap-up.
Thanks so much, Jenna. That was really helpful. So we wanted to circle back to our 4 key questions that we started with. So first, why do digital health innovations scale in low resource settings at a different pace, sometimes slow and sometimes fast? And we learned that market needs actually vary by digital health maturity, and this is the country digital health maturity level. Scale accelerates when the product attributes fit the market need, where there's appropriate capacity to support scale, and financing flows throughout the entire value chain. We found that financing had a ripple effect in the value chain across other actors. Does development actor behavior accelerate or hinder the scale of digital health innovations in low resource settings? Our second question. And we found that scale and sustainability require reliable financing for ongoing operating expenses. So this was a big finding in our work, is that operating expenses, as Jenna just described, make up the majority of the total cost of ownership, and also that it receives less funding. Third, what are the biggest structural incentives preventing digitally enabled health system? And here we found that philanthropic investors can collectively catalyze a solution for the operating expense challenge, but doing so would require restructuring of incentives within funding agencies, and in particular, funding more holistically rather than in silos. And then last, what is the value proposition for digital health investors and to what cost? Digital health investment has potential to save a significant number of lives, given it can work across multiple health areas. Jenna shared with you our impact model. We do have data behind that model. It's currently in peer review publication. So we hope to be sharing that with you shortly once it's in the public domain. And we also found that operating costs are a large component of the total expenses and are often not accounted for in budgets. So next slide. So that concludes the presentation. We were hoping that you could write something in the chat about one thing you've learned that you'd like to reflect more deeply on and pose that as a question. And I do see a few questions also in the chat that we can move to after we see your thoughts on this. Thanks so much.
Thank you very much, Miss Tara and Miss Fritz. Now we are open for the questions. You may type them in the chat box or use the raise hand button and we can call your name.
Yes, Dr. Kim, this is Alvin. I have a question above the chat boxes about just quickly differentiating CAPEX from OPEX. These might be terms that are not familiar with some of the participants over.
Yeah, that is a great question. And maybe we can move to that first and we can come back to these questions that we would like to understand about what you've learned on. So Jenna, I think if you can move back to slide 7. Thank you so much. So it's a great question. So CapEx versus OpEx we show here on this slide, and we've talked a lot about OpEx, which is the operational costs. And you can see here, and this is really where Jenna's overview of our total cost of ownership came in, that we found that operating expenses make up the largest proportion of the total cost of ownership. And these include costs for maintenance and support, as well as costs that are necessary to support the system end users. And so these operating expenses, not only are they often underfunded, but they also are really necessary for the value chain analysis. And you can see here that the operating costs, looking down those two columns, we see stress in the value chain, and that is because there is not ongoing support for operating expenses. Capital expenses, or CapEx, on the other hand, are costs that are associated with software development and system implementation. These are costs that are often budgeted for more accurately in the total cost of ownership, and could also include things such as hardware, computers, laptops, and all the funding that's needed to actually develop the digital health intervention. And Jenna, there was one more question on slide 8, I believe, and please jump in here if I'm misinterpreting the question. But I believe that you were asking about, on this slide, the populations row. And the total population here is the total population of all of the countries that fit into each of these maturity levels. So for example, in market maturity level 3, which is shown in the middle column, there are 98 countries in that market maturity level. This is the one that has the most countries in it. And if you add up the population of all of those countries that are at that level, it is about 3.5 billion people. So it's trying to give you a sense of most countries in the world actually are in the lower market maturity levels. Those are levels 1 through 3. And you can see that by the populations here that are shown on this slide. Great question. I see another comment in the chat. Just going to read this really quick.
Yes, thank you, Ms. Tara. Another question is from Julius. In low resource setting with heterogeneous level of digital maturity within an area, would focusing on higher level innovation be more benefit, such as for progress, or would it be better for to focus on low level innovations?
That's a great question. Jenna, do you want to take a stab at this one, given you presented this information?
Sure. I do think this is a really important question and potentially beyond the scope of this analysis. But I think the point here is there are certain attributes that are cross-cutting and that would benefit kind of across these different levels, as you can see here. So, you know, cloud-based to promote access, having strong mobile interface. These are all kind of innovations and aspects of products that we heard benefit kind of settings with heterogeneous digital maturity, as the question was alluding to. However, I think it's also important to note that trying to implement and scale systems in lower resource settings, what we heard in the analysis is there are kind of baseline requirements for those settings. So those level 1 through 3, things like offline functionality, SMS, data compression, that those are really critical for user uptake and for sustainability of the product. So important to focus on those innovations kind of prior to moving into more kind of mature or, you know, progressive product attributes. So we did hear from the analysis and from stakeholders that we spoke with that those kind of understanding and accounting for product attributes 1 through 3 are important for those contexts, rather than trying to necessarily focus on kind of higher level innovations that maybe would not have as great of uptake or scale because of the digital health of those contexts. I don't know, Tara, if you have any other thoughts there, but that would be my my reflection.
Maybe just one other thing to add is that it's difficult for a product to meet all digital health maturity levels. And so often products that are more tailored for higher maturity level markets, they need to be adapted for lower digital health maturity market segments. So it's you know, products really need to look at the needs of the end users and to design their products appropriately. And this serves as a checklist in terms of, you know, what attributes are most critical by different digital health levels. But agreed, great question.
Thank you, Ms. Tara and Ms. Jenna. And there is another question in the chat box. What about developing existing softwares and improve interoperability among all of the softwares?
That is really an important point. We did see some discussion about this in our value chain analysis in particular about interoperability. Where we heard about it most often is that solutions often, there's there's many solutions out there for end users. It's quite fragmented, and solutions don't always talk to one another. And so that is why for system users, there's often challenges because they need to learn more than they need to learn about more than one different product in order to access information. They often don't get a holistic picture because solutions are not talking to one another and they are not interoperable. So interoperability is really key for the user experience. It's also critical for getting a holistic picture of what's happening from a health perspective. And that's an area where much improvement is needed. So great question.
Thank you, Ms. Tara. I think Dr. Arin has write his thought after for this webinar in the chat box.
System, like the National Health Insurance Program, paying for electronic claims or proper use of telemedicine. Have you encountered such solutions in your research over?
Great comment and question. And Jenna, maybe you want to go to the OpEx detailed slide for the TCO. This is an area where, we really found, things were breaking down, and I'm glad that you noticed this and flagged this as a key learning. This recurrent training aspect and training in general makes up a large component of the operating expenses. And this is an area that we found was often, not just recurrent training, but all of these different areas within operating expenses are often overlooked in budgets. And so we did fail to see people considering, these types of aspects in terms of maintenance, help desk support for end users, recurrent training, as well as equipment replacement, which we also include as